Welcome everyone to today's clinical rounds. We have two exceptional cases lined up that perfectly illustrates the chaotic, high-stakes nature of medical toxicology. These aren't just textbook ingestions. These are complex and multi-layered presentations that challenge our initial diagnostic algorithms and focus or force us to rely on our understanding of fundamental pathophysiology. First of all, um, let's, you can drop your questions during this webinar. You can drop your questions here in the chat box. Just make sure to share it with everyone, not only the panelists. Also, we will have, this is 1 hour, as usual, it's 1 hour session. We will present these two cases. We will have a discussion meanwhile. So first we have um, Dr. Bahar Zidan, who will be presenting a fascinating case of an acute chemical chemical inhalation injury, what I like to call the silent chemical burn. And um, after that, we will have a different case of polypharmacy overdose that resulted in severe presentation. So, Dr. Bahar Zidan, the floor is.
Yes, well, thank you for the introduction, Doctora. Good afternoon, everyone. My name is Bahar. I'm an emergency medicine resident here at SKMC, and today I'll be walking you through a case that came through our emergency department, one that really tests how we think about undifferentiated shock in a young patient. So let's start with the case. Next slide, please. Thank you. So we have a 22-year-old female with a known history of depression who presented to the ED department with a decreased level of consciousness for the past 2 to 3 hours. Her mother told us that there was one episode of vomiting followed by 30 minutes of unresponsiveness before they brought her in. Now, here's the first challenge with this case. The history was unreliable. The patient kept changing her account of events every time we asked. So already before we've even touched the patient, we know we're gonna have to lean on our examination and our investigations rather than the story alone. So moving to our initial assessment to the ED. Yes, so her GCS was 15 out of 15, but she was drowsy. Heart rate was 104, and remember, the number that really jumps out was the blood pressure of 62/30. Otherwise, her vitals were within normal limits. So we started the patient immediately on IV normal saline. However, her hypotension was refractory to fluid resuscitation, and she wasn't responding the same way a simple volume depleted patient should. So her ECG.
Yeah, sorry, just, let us hold on a moment here. So, the audience, so we have this 22-year-old with systolic blood pressure in the 60s, and yet her venous lactate is entirely normal. It's 1.5. And then, how is it physiologically possible to be in profound shock with an elevated lactate? So, at this point, what you expect given this, can we have any insights in the chat? What do you think about this case? Any predictor of severity you can use? Which levels you need to send at this point? You can see any insights?
Okay, so what
First.
medications was given by the EMS? So in the EMS, the patient was a little agitated, so they gave her a small dose of midazolam. TCAs, calcium channel. Okay.
Because okay, let us go to the next. Just when we think let us go to the next slide so we can give a little bit more insights.
Okay, so this was her initial ECG. What do you guys think? Any abnormalities? Perfect. So yes, the QTC was 503, which is a little bit prolonged. Otherwise, sinus rhythm, no obvious abnormalities. Okay, so if we can move to the VBG, Doctora.
Mhm.
So this was her initial VBG. And if you notice here, her lactate is only mildly elevated, even though she is severely hypotensive, which is a bit unusual, and it's telling us that there's something about the mechanism of her shock, even if we don't know what that is yet. So what would be your differentials at this point of the case?
So to make it a bit easy for you, think about something that will maintain your cardiac output, but at the same time may cause the profound, peripheral vasodilatation.
Okay, beta blocker.
This is actually related to the time of exposure. So not all the cases are like this, but depending on at what time you catch your patients or your patient comes in. Maybe let's continue.
Yep. So what other history or investigations would you prioritize in this patient?
Which type of tests you would think for? Uh, would you
At
think
this
to
point,
send
oh, sorry.
some electrolytes and send for blood glucose?
Yeah, so at this point, there was no history of ingestion, but moving forward, we will find out.
Urine screening, it's something interesting, helpful. However, it's limited. Urine screenings, they have it's an immunoassay that is available in hospitals. It will help to detect. It's a positive, negative. It's qualitative rather than quantitative. It's different than paracetamol and salicylates, who are quantitative tests and may confirm exposure. However, urine screen, they detect by family of drug, and then even if you have positive, it may be false positive with other interference. And if you have it negative, maybe you are having false negative, which is, for example, compound not detected, or the concentration is not enough to trigger the positive result, considering the cutoff. Antidepressant was shown toxicity. Toxicity, yes, as we said, it's maybe helpful for paracetamol and salicylate levels. Ethanol also is one of the toxicity levels. Other antidepressants, so it depends. Bahar, you can continue.
Yes, if you can go to the next slide.
Yes.
So here we got the timeline of the ingestions of the tablets that she took. So she reported taking 6 tablets of paracetamol 2 nights before the presentation and 9 tablets the night before. Then 9 hours before arrival, she took a combination of 24 tablets of paracetamol, 3 tablets of alprazolam, 6 tablets of bupropion with 4 shots of coffee. So now we have a polypharmacy overdose and everything we saw earlier, refractory hypotension, and the prolonged QTC. This all needs to be interpreted in that different light, basically. So moving on to what we did in the ER. So next slide, please. Yes, so as we mentioned, the patient already received 1 liter of normal saline, and she was given ondansetron in preparation for giving activated charcoal. Her BP was still not improving, so we gave her 30 units of insulin with D50. However, the BP still did not improve, so we started the patient on norepi through a peripheral line while preparing for a central line insertion. We gave the second dose of insulin, 70 units with D50, then 3 grams of calcium gluconate and potassium chloride. We also gave 10 milligrams of glucagon as bolus, followed by an infusion at 5 milligrams per hour, and we started the NAC2 back protocol. Then we consulted both toxicology and the ICU. So at this point, while we were giving all these medications, shifting her to resus, starting the central line, the patient confessed to taking her father's blood pressure medications, which later asking the father found out to be amlodipine. So now it kind of clears up the image for us about which toxidrome we're going mostly with. So with the toxicology recommendation, if we can go to the next slide, please.
Yeah, before going that, so to that, I wanted to emphasize something really, really important, which is regarding the history. So having the history, sometimes it's helpful, and on other occasions it will cause for us another, I mean, open for us another door, which is like we will think about which medication he took, or she took, and then you will or underestimate the clinical severity or presentation. So for this, for example, this clinical picture for this patient, if we consider the amlodipine, the dihydropyridine calcium channel blocker, and once we think about the initial presentation, it's always causing this precapillary vasodilatation. We will have the normal lactate and without metabolic acidosis. So early on, the cardiac output, it's often like maintained, and the tissues are still extracting oxygen efficiently. So for this patient, shock is a state of inadequate tissue perfusion, not just a low blood pressure number. So if you see for patient vasoplegia without lactic acidosis, always think about calcium channel blocker toxicity before the profound myocardial depression sets in. Here regarding the management, if we say we are giving or we gave 1 liter normal saline, for me it's for me for calcium channel blocker, always like given 1 liter. It's something I know that it's something like we are tend to go for it. Like we are given IV fluids. It's systematic for patients when we have low blood pressure. However, when we think about this patient, anyone in the audience can share in the chat what's the risk for this patient when we give this 1 liter, normal saline initially. You can answer in the chat about the risk, and I will let Bahar continue with the next slide, and then we discuss this point.
Okay, I think the answer will be in this slide. However, the toxicology recommendation after consulting them was starting high-dose insulin, which already was started. So 0.5 to 1 unit per kilogram per hour with D10 infusion, escalating it to 2 units per kilogram per hour if needed, if the patient's BP is not responding. And you assess the patient after every 30 minutes with a maximum dose of 10 units per kilogram per hour. They emphasized on using a concentrated dextrose insulin solution to limit fluid intake, maintaining a glucose level between 100 and 200, and keeping potassium above 3 milliequivalents per liter. They also noted that methylene blue and intralipid could be considered if she wasn't improving, but caution with giving intralipid if you are thinking of starting ECMO in this patient. And if she developed fluid overload, yep, the recommendation was to start hemodialysis rather than stop the high-dose insulin. And when it came time to wean support, the sequence was to wean vasopressors first and then insulin. So reading the answers here, pulmonary edema, risk of pulmonary edema. Okay, perfect.
Yeah, excellent. Yeah, excellent. We have this risk of liquid overload. This is something if we already know in the beginning that the patient took amlodipine, so the recommendation would be avoid liquids. We can use the bolus that we use initially to do the access, IV access, etc. This is allowed. However, given like the fluids to help the blood pressure, raise the blood pressure, it's not recommended. Another thing really important in always you need to think about it whenever you have this such patients is to ask your pharmacist, ask your clinical pharmacist or pharmacist about concentrating on maximum this high dose insulin. This is one thing. Given high dose insulin with the normal, I mean the dilution that they are using for endocrinology, this will cause this fluid overload. And if you go to dig in the literature for these cases, always we will have this complication of fluid overload for these severe patients if they took a phenomenal amount, and we need to have this high dose insulin for a long time. So this is one of the risks. I had the patients who spend like a long period in the ICU regarding this to overcome this complication. So this is important. Second thing you need to think about is about the fear of giving high dose insulin. This is very common. And if we go back to the slide, we will see if you consider the dose of high dose insulin, the dose should be it should be 1 unit per kg up to 10 units. So you start with 1. So always when I had discussion with the colleagues or physicians, or so when you had this discussion to start 1 unit per kg, so always we have this fear of hypoglycemia. For this patient, think that this is first line therapy. This is something, I mean, with evidence based, like, I mean, recommendation. So this is first line therapy. The patients, you can, even the severe patient, they will have hyperglycemia as a predictor of severity. This is really important for this patient. You need to send it to do your finger stick glucose or send it. So you need to check that. And when you treat the patient, the hypoglycemia, the risk of hypoglycemia is there. You have just to give boluses to cover that, and you like doing your monitoring of given a small amount, you are just delaying the care. You are just giving more fluids with that. This is an example of giving, for example, 30 units and then 70 units. So start with 1 unit and then think about, I mean, think about increasing the dose up to 10 units per kg if no response is there. Other thing we need to focus on is about we spoke about IV fluids, the risk of pulmonary edema. You answered this. So we need to abandon the volume expansion immediately for these patients. Also, we need to discuss another point we had, I think, a question regarding activated charcoal. Activated charcoal, actually, we are interested to share some insights. We had a new, I'm not sure if you had a chance to check it, the new, I mean, consensus, the latest recommendations. As I remember, it's in April. Was in April or May about it, this paper. So we have actually, there is some recommendations to do the additional dose of activated charcoal on some substances, but generally mentioning that 9 hours post ingestion. So this is depending on the decision of the team, depending on the reliability of history. if there is any chance that the patient took a few hours ago or 1 hour ago before coming there. History limited initially the suicidal patient, they will not admit what they took. Conditions are there, no vomiting, no drowsiness. So for sure you can do, you can give active charcoal if it's, I mean, a drug, not a caustic, you know, the caustic. A few things to add here. We were in the diagnosis, yeah, here.
Perfect. So we know the diagnosis is intentional polypharmacy overdose from multiple drugs from multiple classes, but the predominant one was the calcium channel blocker toxicity, which was causing her instability from the vasodilatory shock that was refractory to fluids. Other co-ingestions can cause risks of seizure, hepatotoxicity, and alprazolam could have caused her drowsiness in this case. So coming to the next discussion part, would you have escalated therapy earlier or differently from her first presentation, not knowing about the calcium channel toxicity?
Any experience with IV lipid emulsion and trilipid emulsion in the audience? You can share if you saved patients with this. It's the rescue treatment for patients. Actually, it's not something really specific. The mechanism is just, I mean, work directly to trap the drug and take it out from the, I mean, the blood. This is a rescue treatment that we go for it if our first line therapy or second line therapy is not working. So for these patients, if we have liquid overload, if you have this, I mean, this patient deteriorating, you can go to do it, I mean, as a bridge as well to other treatments. However, the high dose insulin is having really good results for such patients, and it's beneficial treatment. For the amlodipine cases. The only is that we always try to work on it. We know that it's difficult. However, the pharmacist may help on concentrating the liquid to have best outcomes for these patients. Any question on this case before going to the next case? In refractory, I mean, cardiogenic shock from calcium channel blockers, the ECMO for sure is the final lifeline. So if we push intralipid and that lipid emulsion will, I mean, fool the ECMO circuit, clogging the oxygenators and essentially turning a life-saving machine into a block of fat. So that's why we must, I mean, choose this salvage therapy carefully, given like lipids can sometimes like burn your bridge for mechanical support. So this is like, I mean, it's really important questions that we should, I mean, think. Because this is why, I mean, if we want to activate ECMO, we should avoid that. Other thing for this patient, there are as we mentioned, there are many risks, risk of seizure. So from bupropion, bupropion also may cause that QRS widening. However, I want to highlight that sodium bicarb is not effective on that. As per the mechanism of action of bupropion, it's not something working on sodium channel blockade. No, it's working on potassium channels and different mechanism causing that widening of QRS complex. So that's why no role for the calcium for the sodium bicarb. So the seizure threshold should be, lowered due to bupropion, and then also we have. So when you think about treatment, always for alprazolam, it's helpful. Sometimes this patient is, the patient himself is treating himself by taking this mixture overdoses. Thank you so much, Bahar, for this great presentation. Thank you so much. Let's go to the next presentation. We still have, let me add, we can have more 4 minutes, Bahar, because we start at 5. We can add more 4 minutes and then we go to the next presentation.
Okay, perfect. So just going through amlodipine, basically it's a dihydropyridine calcium channel blocker, primarily selective for vascular smooth muscle, so it blocks the L-type calcium channels, causing arterial vasodilatation, and it also impairs pancreatic insulin release, which shows in our VBG as hyperglycemia. So in overdose, that receptor is selectively lost. So we can also see myocardial depression and conduction abnormalities, which explains the QTC changes we saw in her ECG. The hallmark finding in these overdoses are reflecting the impaired insulin secretion from the pancreatic calcium channel blocker is hyperglycemia. And how do we manage them? Doctor already went through it, but again, calcium gluconate or calcium chloride partially overcomes the calcium channel blockade. And most importantly, the high-dose insulin, euglycemic therapy, which improves the cardiac inotropy and myocardial glucose and lactate utilization. But we still have to monitor the potassium and phosphate closely every 30 minutes. And the insulin should be concentrated to avoid, as we mentioned, fluid overload. Glucagon bypasses the blocked calcium channel entirely through the CAMP-mediated pathway, improving the contractility independent of the calcium channel. And vasopressors, specifically norepi, are used for refractory vasodilatory shock. And in truly refractory cases, we can consider IV lipid emulsion therapy or even ECMO, however, not both at the same time. So, take home message, consider toxic ingestion in any young patient with unexplained refractory hypotension, especially when the history is unreliable. Hyperglycemia plus refractory shock can raise your suspicion for calcium channel blocker toxicity specifically, and that's when you need to start the high dose insulin. And early recognition and multimodal therapy is important. Calcium, high dose insulin, glucagon, and vasopressors all used together rather than sequentially, waiting on each other. Finally, don't forget the co-ingestions. So in this case, NAC and benzodiazepine monitoring remain essential in any polypharmacy overdose, even once you've identified the dominant toxidrome. So for my patient, she went into the ICU for 2 days. They weaned her off the norepi on the first day, and they weaned her off the insulin on the second day, and she had a full recovery. That's it for my case. Thank you for having me. Hopefully you learned
Thank you so much.
something new
Thank
today.
you.
Thank you, Doctor.
Thank you so much. Thank you. So always remember that always remember that the high dose insulin, like it's the last thing that you stop after weaning off your treatment. So we can go now to the other lecture for the other case. Let me stop sharing. Dr. Mohammed Amin Bakiro. This is for the second case we have today. This is about chemical injury. The floor is yours.
Assalamu alaikum. Hello, everyone. Am I audible? Can you hear me?
Yes, we can hear you.
Okay, great. Assalamu alaikum, everyone. My name is Mohammed Amin Bakiro. I am a third-year emergency medicine resident at Sheikh Khalifa Medical City. And to continue the discussion, today we will be having a second case on MENATOX Clinical Rounds. From the title of the presentation and the picture you can see, it's I chose to call it the room that took her breath away. We're referring to the patient. So going through the cases, we'll find out more about what happened to this patient. So let's start with this lady. Next slide, please. She's a 36-year-old female who is previously healthy, not known to have any medical comorbidities. Next slide. She presented with acute onset of shortness of breath beginning approximately 6 hours prior to her arrival to the ER. So she was at her baseline in her house, and then suddenly she felt a little bit shortness of breath, and that shortness of breath was worsening, and it was getting more and more severe. It was associated with dry cough, and she was getting more and more increasingly respiratory distressed in her respiration. She denied any history of asthma, chronic lung disease, recent medication use. She's not a smoker. She denied the history of chest pain, fever, or any sick contacts, or any flu-like symptoms. And she also reported that she's feeling a sensation of suffocation in her throat. And that's when she thought that she requires to come into the hospital, and she called in an ambulance. So just to recap, so far we only have a 36-year-old female, previously healthy, in respiratory distress. Yes, please carry on, next slide. So on arrival, she appeared very much unwell. She had respiratory distress. She was sitting forward in the stretcher. The ambulance had given her a little bit of nebulizations because they thought could be an asthma exacerbation. So she was on salbutamol and nebulizer. We moved her to the bed. She looked quite uncomfortable. On auscultation, she had bilateral inspiratory and expiratory wheezing with reduced air entry diffusely, but when you hear it, it's mostly just wheezing sounds. For her vital signs, blood pressure was normal, heart rate was 127, tachycardic, respiratory rate is 32. She was afebrile, and she had an initial saturation of 88% on room air. The rest of the body examination is not significant. So from here, from the discussion and so far all that you know about this patient, what do you think some of the differential diagnoses? You can think of some of the stuff and you can share it in the chat box below, please.
Yeah, so before we move
And already
forward, before we move forward, we want everyone in the audience to look closely at these initial vitals. So we have this 36-year-old female with severe respiratory distress, Tripodin with heart rate 127, blood pressure 133 over 118. So drop your answers in the chat and remember to send to everyone. So do we trust this blood pressure? What is this? I mean, extremely narrow pulse pressure telling us in the clinical context. Do you need any tests? Do you need to see to the VBG maybe? Is there any clinical something, any, which pertinent tests you would think for, or which are your toxicological differentials?
tachycardia and tachypnea, blood gas, inhalation injury, CO, cyanide, methylhydramine.
Excellent thoughts in the chat. But guys, if you think about the pulse pressure, if we think about, I mean, until in a patient who is tachypnic and tripodin is almost certainly an automated cough artifact. So this is, I mean, would be driven by the extreme respiratory variation, essentially pulses paradoxus. So as toxicologists, we must treat this patient, not the monitor. So when you see the number that don't match, I mean the physiology, you need to think. Otherwise, we have here anaphylaxis, non-toxicology cause. Let's go, I think, for the blood gas to have the full picture. What are the two tests here that will help you to rule out some differential diagnosis? Okay, it's not carbon monoxide. In toxicological point of view, we have a carbon monoxide and methemoglobin here. So this is what interesting for us. So this patient, in any patient collapsing in a poorly ventilated space, you must explicitly rule out the carbon monoxide and also methemoglobinemia early, which is, I mean, which this gas effectively does. Maybe we can move to the next, to the collateral history.
Yes, please.
Ingestion. Okay.
So we already discussed the differential diagnosis.
Yeah.
So let's move on. So this is an ECG for the patient. So from your interpretation, what can you tell about any finding that you can see on the ECG? QTC, yes, we have somebody in the comment mentioning about the QTC. Yeah, it's borderline prolonged, 470 milliseconds. Okay, let's move on to the next test. So this was a chest X-ray plain film of the patient. This was a portable film, so mind that while you're interpreting it for poor inspiratory effort and rotation. But what can you see from the interpretation? Anything? So just not to take longer, you could see a possible bilateral central congestion. Mild, it's not diffuse, but there is some increased bronchovascular marking bilaterally, perihilar. Yes, possibly pulmonary edema. Okay, so let's move on. So this patient was initially managed in the ER. Well, I was the person who saw her along with my attending. When we saw that kind of picture, so we were not sure that this patient had any sort of anaphylaxis or exposure to anything. So we managed her as an anaphylaxis at the beginning. So we gave her IM epinephrine, 0.5 milligram, and shot of steroids, methylprednisolone 125 milligrams, and we continued with albuterol. And then because she was mentioning and she was holding her neck a lot and she was mentioning that suffocation feeling, I thought also of giving her a dose of nebulized racemic epinephrine. So we went ahead and gave that, but still that did not give her much of an improvement. So there was minimal improvement between these interventions. So we thought that because of her increasing tachypnea, respiratory effort, and because of what you saw on the blood gas, she is tachypnic. So maybe she could benefit from a non-invasive ventilation. So we started her on BiPAP. For both hypercapnia and for the poor respiratory effort that she had. I mean, the increased respiratory distress that she had. So far, these are the intervention. And moving on, these are some of the lab investigations that were done. And on the right side, you see a repeat blood gas after almost 2 hours of being on non-invasive ventilation. Pregnancy test was negative. Her liver function was normal. Can we go back? So she had a borderline elevated leukocytes, but there was no neutrophilia. So that was mostly due to stress. Her hemoglobin was stable. and platelets were also stable. And only we have from the liver function just a slightest elevation in AST, which is insignificant in my opinion. Blood gas, she is hypoxic. Well, sorry, this is a venous blood gas. We cannot really comment on it, but she's having lactic acidosis of 2.9. Next slide, please. Yes. So up until this point, all what we had from the patient is that she was severely respiratory distressed. She was not able to give us proper history. She was mainly due to the respiratory distress along with the language barrier. So what we had her friend by her side arrive, and then she gave us more history. So she told us that this patient actually works as a house cleaner. And she was at a client's house a few hours back cleaning a specific room. That room was poorly ventilated, and a part of her cleaning process, she mixed multiple products to maybe have a deeper clean. And she finished her job, almost stayed 3 hours in the room. And then after that, she took a taxi and then she went back to her home, which between the cleaning and going back to her home was more than 6 hours period. And when she was at home, after 6 hours almost of the exposure, that's when she started developing the symptoms. So let's move to the next slide, just to go over the things that she did. So like what we said, she works as a cleaner. She mixed both bleach, vinegar, and Dettol. And she was sitting in a room. She put all of 3 of them in a bucket, and she was using this to wipe and clean. And the room was poorly ventilated, and she stayed there for 3 hours. And at the time, there was no symptoms whatsoever. It's only several hours later, almost more than 6 hours, when she went home, that's when she had the symptoms start. So I already have some people in the chat mentioning, yes, chemical pneumonitis.
So we can stop here. We can just pause here. So you mentioned a very critical piece in the timeline. So she was mixing these products, and then which we know that it might produce different products, different gases. And then, so if I were to spray, for example, ammonia in this, for example, in a hall where we do a lecture, for example, every single one of you would run out coughing in 10 seconds. So yet she remained cleaning in that poorly ventilated room for 3 hours without, noticing severe symptoms. Why? So I would ask the audience, what toxicological principle dictates this delayed presentation?
Yes. That's a very important question.
Yeah.
And we have to understand this point. So let's try and brainstorm.
So we see now some, Muhammad, he shared with us very excellent point regarding when we mix, we will have different products. If we mix the Clorox with the acid, we will have the chlorine gas. Chlorine gas is the most, famous that we know about it. However, if we mix it with ammonia, we will have the chloramine. So this is, different gases, but the effects are similar. We have actually, when we think, so when we spot on for those, when we spot on those thinking let me check if there is any answer regarding this point. No. So no one mentioned solubility. So this is a deadly trap when we think, which is, the intermediate water solubility. So highly soluble gases like ammonia, it dissolves instantly in the moisture of the eyes, upper airway. So this will cause immediate excruciating burning that acts as a warning property, forcing the patient to flee. So this is important for the gases, the highly, irritant gases. However, when we think about chlorine gas, it has intermediate water solubility. So it partially bypasses the upper airway and travels deep into the lower respiratory tract. So over those 3 hours, it slowly reacted with mucosal water to form hydrochloric acid and hydrochlorous acid alongside oxygen-free radicals. So this all will cause the oxidative stress causing that profound presentation or delayed presentation. So this is the silent period, which is, the hallmark of intermediate solubility gases, and this is exactly why she sustained such a massive accumulated dose. So this is really, really important.
Okay. So moving on, next slide, please, Doctora.
Actually, something was interesting for this patient. There was no, ocular findings or something. So this is maybe related to the initial reaction that she is not membrane at that time. She's like having only the delayed presentation, not the acute thing that may occur initially.
Yes, so in a management perspective, these cases, the management in the literature, if you look at it, there is no specific antidote that is used for this gas. The treatment is just supportive. So these patients, they need to be monitored in a hospital setting. So this patient was admitted under internal medicine service. She had a repeat blood gas upon her discharge the next day, which you can see on the right side. Just for me to give you a few words about her course of admission, she had a course of admission of just less than 2 days. So she was initially admitted on NIV, which made her feel much more better. They were able to wean her off to high flow and then to oxygen, like minimal oxygen support. And then she just needed some nebulizations in between, whether it's albuterol or budesonide nebulization. And then upon repeated examination the next day, she was doing fine. Her bilateral air entry was improving. There was no wheeze of any sort. She was given a discharge with an early follow-up within 1 week, which unfortunately she did not attend. But one important thing in these patients is that education is very high yield and very important in these patients because they are at risk. That's her occupation. That's something she does on a regular basis. And probably she did this in the past, but maybe she was lucky enough to have it done in a room that is probably more well ventilated or in an open space that it minimally affected her. So education was given to the patient to avoid mixing any sort of products together. And if she feels this sort of distress, to make sure she goes into an open area, she is a well ventilated space, and then she to seek immediate medical attention. So she made a full recovery. Just to have few words to brush up on what Doctor had already said. Please, Doctor, next slide. So just to recap what Doctora said, to highlight the important points. So sodium hypochlorite, which is the bleach, if it's mixed with acetic acid, which is present in vinegar, it will create this dangerous gas. You can see it in the formula, and it's usually found in all of these cleaning products. And this it's a toxic gas, and it's heavier than air, and it's easily accommodates in an area that is poorly ventilated. Next slide, please. So like what Doctora said, it's intermediate water solubility, unlike ammonia, which causes immediate irritation. This gas specifically takes time. So patient might have the exposure happened few hours earlier, but during this time where the patient is asymptomatic, the gas had traveled to the lower airways and caused airway irritation, and that puts them at risk of having this severe reaction. So a severe form would be having a picture of pulmonary edema or ARDS, and there are reported cases of these things. Possibly our patient had an early form of ARDS that was managed early with the non-invasive ventilation, and thankfully she made a good recovery. So that's for my case. And if there is one thing that you can take away from this patient and from this history, is that always investigate deeper in your history, because there was nothing that could have clued us into her case if we didn't dig deeper in the history, because she clearly had finished cleaning and she went back to her home, and those symptoms happened completely separate of the incident that the cleaning space was happened in. So maintaining that high index of suspicion and digging deeper to find these clinical clues and history clues to get you into your patient. And once you find them and diagnose them, make sure you give them the proper education to avoid having this done in the future. And that's it for my part. Thank you very much. Thank you also,
So
Dr.
much.
Samia. If you have
Thank
any
you.
questions, please drop them in the chat.
Thank you so much, Mohammed, for this presentation. Yeah, it's totally true that the history is really, really important to guide you on the treatment. And regarding, for example, the epinephrine, if we think about it for such patient, if you don't have the history adequately, will go to anaphylaxis, and epinephrine is not for in the chemical inhalation. It would not help, and sometimes it may even increase the medical oxygen demand. I mean, it's not helpful for this, I mean, patient. Also, a question which is actually not recommended and having a controversial. And let me go to the chat. Yeah, we had it here. Question regarding. Locate the question. 1 second. Yeah, it was the sodium bicarb nebulizer use. So I would like to share. It's something not it's supported by animal models mainly, and some case series. However, it's theoretically neutralizes the acid species formed in the lower airways. However, it's something, I mean, supported with some emergency and hazmat guidelines supporting that it will do maybe prompt symptom relief. However, critics argue that the buffering reaction itself using that may cause a mild exothermic reaction or local irritation. So it's not something really, it's controversial. It's something not, we don't have like, I mean, official like consensus on its efficacy or use in those patients. So something I would like to mention before we close the session, which is, I mean, when we mentioned that patient improved and discharge is something very good for us, a good outcome. Sometimes we need to think also about our follow-up when we need to have it. So for this patient, we have the long-term pulmonary complication that must be, I mean, counseled, and then which is, I mean, the reactive airway dysfunction syndrome. So this patient, a single massive exposure to an irritant gas can permanently alter the airway architecture, leading to irritant-induced refractory asthma. So this patient should be, continue a follow-up with internal medicine. Maybe it's not enough as well. This patient will require as well the aggressive outpatient pulmonary follow-ups, baseline spirometry and long-term surveillance to avoid such, sequelae and such long-term issues. Do you have any questions? Let me check. So to summarize the today's sessions, we had about this chlorine gas or these gases for chemical pneumonitis causing this massive, pneumonitis, and then we had the other case of amlodipine overdose and the high dose insulin, and so thank you so much for the presenters for bringing this incredible cases. And thank you all for your active presence, for your attention, for your questions, active presence here. Thank you so much. And I would like to invite you to join us in next clinical MENATOX Clinical Rounds, 11 August, where we will have the clinical toxicology competition. It's really, really important to join, guys. It's really interesting. And I wish to meet you 11th of August. Stay safe. and see you then. Thank you so much.